Your body speaks a language most of us never learn to hear, and sometimes, what it whispers through your skin, your eyes, your breath, is a warning about your heart. We walk through our days inhabiting these extraordinary vessels of bone and tissue, these intricate networks of pulsing rivers we call arteries and veins, and yet we remain strangers to the signals they send. There exists within us an ancient communication system, older than language itself, older than consciousness as we understand it. Long before we developed the capacity to speak about pain or discomfort, our bodies evolved mechanisms to display their internal struggles on the surface, to paint distress across the canvas of our skin, to sculpt warning signs into the visible architecture of our physical form. This is not poetry. This is biology expressing itself through the logic of survival. Consider for a moment the profound intelligence embedded in this design. The cardiovascular system, that magnificent pump and its vast network of tributaries, does not fail silently. It cannot. Every cell in your body depends on the oxygen and nutrients that blood delivers, and when that delivery system begins to falter, the body must respond. It must adapt. It must signal. Evolution has written into our very structure a kind of early warning system, a visual telegraph that announces dysfunction before catastrophe arrives. The heart, hidden behind the fortress of the ribcage, beating in darkness, nonetheless finds ways to make its struggles visible to the world outside. This is what separates preventable tragedy from intervention. The body gives us time. It offers clues. These signs that appear on our skin, in our eyes, in the subtle changes of color and texture and form, they are not random. They emerge from the same physiological cascades that threaten the heart itself. When cholesterol begins its slow accumulation in arterial walls, when blood pressure rises beyond sustainable thresholds, when oxygenation falters and circulation compromises, these internal processes create ripples that reach the surface. The same narrowed vessels that strangle the heart also feed the skin. The same metabolic disturbances that build dangerous plaques also manifest in visible deposits. The same failing pump that struggles to nourish vital organs also betrays itself through swelling and discoloration in the periphery. What we are really discussing is the interconnectedness of biological systems. Nothing in the body exists in isolation. The heart does not suffer alone. Its distress radiates outward through 1,000 pathways, and some of those pathways terminate in places we can see, places we can touch, places we encounter every morning in the mirror. Understanding these visible signs is not about fear. It is about literacy in the language of your own biology. It is about recognizing that the boundary between internal and external is more permeable than we imagine, that what happens in the hidden chambers of the heart eventually writes itself across the surface of our being. There exists a peculiar marking that appears on some earlobes, a diagonal crease that runs from the lower portion of the ear canal downward toward the edge of the lobe, slicing across the soft tissue at an angle. For decades, physicians noticed this seemingly insignificant fold appearing with curious frequency in patients who had experienced heart attacks or who carried significant cardiovascular disease. It seemed almost too simple, too visible, too external to mean anything about the hidden workings of coronary arteries. And yet the correlation persisted across populations, across studies, across continents. This marking, named after the physician who first documented its clinical significance, forces us to ask a deeper question about how blood flow shapes the geography of our bodies. The earlobe is one of the few structures in human anatomy composed almost entirely of soft tissue with minimal cartilage, depending entirely on a delicate network of tiny blood vessels to maintain its structure and vitality. Unlike other parts of the ear, which are scaffolded by cartilage, the lobe is vulnerable, responsive, exquisitely sensitive to changes in vascular supply. When the larger arteries that feed the heart begin their gradual narrowing through the accumulation of atherosclerotic plaque, this same process unfolds throughout the arterial system. The vessels are not independent entities. They are branches of the same tree. The pathology that compromises coronary blood flow simultaneously compromises the microvascular networks in peripheral tissues. What happens in the earlobe tells a story about what happens everywhere. As these tiny vessels narrow and stiffen, as their walls thicken with the same lipid deposits and inflammatory changes occurring in major arteries, the tissue they nourish begins to suffer. Collagen and elastin, the structural proteins that give skin its resilience and form, require constant nourishment. When blood flow diminishes, when oxygen delivery falters, these proteins degrade faster than they can be replenished. The tissue loses its integrity. It begins to collapse along lines of mechanical stress. The earlobe, subjected to gravity and the weight of its own tissue, develops a crease along the path of least resistance. This is not mere coincidence. This is vascular insufficiency writing itself into the landscape of the body. The same endothelial dysfunction, the same arterial stiffness, the same inflammatory cascades that threaten the myocardium also reshape the earlobe. Think of it as a window into systemic arterial health, a place where the skin is thin enough and the tissue simple enough that vascular compromise becomes visible. Not everyone with heart disease develops this crease, and not everyone with the crease has heart disease. Biology resists absolute rules. But the association reminds us that the cardiovascular system is exactly that, a system, and its deterioration leaves fingerprints in unexpected places. When you see that diagonal line carved into the earlobe, you are witnessing the architectural consequences of diminished blood flow, a visible echo of invisible arterial decline. Around the delicate skin of the eyelids, sometimes small yellowish patches appear, soft bumps or plaques that seem to emerge without pain or inflammation. These are not infections, not injuries, not the result of any external contact. They are deposits of cholesterol that have accumulated beneath the skin, visible manifestations of lipid metabolism gone awry. The medical term captures their essence, but what matters more is understanding why they form and what they reveal about the chemistry occurring throughout your vascular system. Cholesterol itself is not a villain. It is an essential molecule, a building block of cell membranes, a precursor to vital hormones, a substance without which human life could not exist. But like so many things in biology, balance is everything. When cholesterol levels rise beyond what the body can effectively process and transport, when the delicate equilibrium between different lipid particles shifts toward dangerous ratios, excess cholesterol begins seeking places to settle. Some of it infiltrates arterial walls, beginning the slow construction of plaques that narrow and harden blood vessels. Some of it finds its way into the skin, particularly in areas where the tissue is thin and rich with tiny blood vessels. The eyelids become a gallery for this excess. Macrophages, those cellular scavengers of the immune system, attempt to clear the accumulated lipids and become engorged with cholesterol themselves, transforming into foam cells that cluster beneath the skin's surface. These yellowish deposits are essentially lipid storage sites, visible proof that your body is struggling to manage its cholesterol burden. What you see around your eyes mirrors what may be happening inside your arteries. The same biochemical process, the same metabolic disturbance, manifests both as these superficial plaques and as the far more dangerous atherosclerotic lesions forming in coronary vessels. The skin becomes a diagnostic canvas, displaying in miniature the lipid chaos that threatens the heart. There is a particular transformation that occurs when oxygen fails to reach the tissues in adequate amounts, a color change so distinctive that it has its own name in medical language. The fingertips, the lips, the nail beds, sometimes even the earlobes take on a bluish or grayish tint, as if a shadow has passed beneath the skin. This is not pigmentation. This is the visible signature of deoxygenated blood, hemoglobin molecules stripped of their oxygen cargo, absorbing and reflecting light differently than their oxygen-rich counterparts. What you are witnessing is a failure of delivery, a breakdown in the fundamental transaction that keeps every cell alive. The heart's primary purpose is remarkably simple in concept though staggeringly complex in execution. It must pump oxygenated blood to every corner of the body and return deoxygenated blood to the lungs for renewal. When the heart weakens, when its chambers no longer contract with sufficient force or when valves fail to open and close properly, circulation slows. Blood lingers in the capillaries longer than it should. Tissues extract whatever oxygen they can, but the sluggish flow means hemoglobin surrenders more of its oxygen than normal before moving on. The blood darkens. Through the translucent skin of lips and fingertips, this darkness shows through as blue. Sometimes this color change appears in the extremities first, the fingers and toes farthest from the heart, where circulation is most tenuous. This peripheral cyanosis tells you that blood is not returning efficiently from these distant outposts. Sometimes the blueness appears centrally, around the mouth and tongue, indicating that even freshly oxygenated blood leaving the lungs carries insufficient oxygen. Either pattern speaks to cardiovascular compromise. The color is a measure of cellular suffocation expressed through skin, a warning that the heart can no longer maintain the oxygen gradient upon which consciousness and life depend. The sensation arrives unexpectedly, a breathlessness that seems disproportionate to the effort expended. Climbing a single flight of stairs leaves you gasping. Walking across a room requires a pause to recover. Your lungs feel as though they are working harder than they should, and somewhere in your awareness, you know this is not normal fatigue. What you are experiencing is not a problem with your lungs at all, though that is where you feel it. You are experiencing the mechanical failure of your heart translated into the language of breath. When the heart weakens as a pump, when its muscle becomes damaged or stiffened or overstretched, it can no longer propel blood forward with the efficiency required. Blood begins to back up in the system like water behind a failing dam. This congestion does not remain abstract. It becomes physical, tangible, observable. Fluid that should stay within blood vessels begins seeping into surrounding tissues. In the lungs, this backup creates pulmonary edema, fluid accumulating in the air sacs where oxygen exchange occurs. Your lungs become waterlogged. Each breath requires more effort. The body interprets this as suffocation and commands you to breathe faster, harder, deeper. Look down at your ankles at the end of the day and you might see the same process written in swelling, in the way your skin holds the indentation of your sock elastic, in the puffiness that was not there this morning. This is fluid escaping the circulatory system because pressure has built up in the veins, because the heart cannot pull blood back efficiently. Press gently on your neck and you might see the jugular veins standing out, distended with blood that cannot drain into a struggling right heart. These are not separate symptoms. They are different expressions of the same hydraulic failure, the same pump losing its ability to move fluid through the elaborate plumbing of your body, turning mechanics into visible distress.